recently I was asked, what do I do differently now over the last decade in my practice? And there were several things. Probably the three that I think are most significant. One is a much greater use of plication. I think I have a technique now that can definitely spare the vessels in plication and get very, very good results, very compatible to resection, so I use much more plication. The use of plication or resection in restrictive strabismus, like Graves' disease. Again, we were always taught not to do that, or Duane syndrome, not to do that in restricted syndrome. But in cases where maximal recession has been done, plication or resection can be very valuable in these conditions. And the third is this one, which I think is more applicable to a larger audience, and that's partial tendon recession for small angle vertical strabismus. This is something that's really changed my practice a lot over the last 10 years. In the past, many patients were satisfied, in America at least, with Prism glasses for small vertical and horizontal deviations, and we have lots and lots of patients with small prisms in their glasses. But recently now, with increasing number of patients prefer spectacle independence for a lot of different reasons, but probably the most important is earlier and better cataract and refractive surgery outcomes. Now patients really can see very clearly without glasses. And again, healthier, more active seniors that want to be able to do sports and exercise and things like that. They don't want to wear glasses, especially if they did when they were younger. Again, in the past, in my teaching from Marshall Parks and others, and my practice for the first 25 or 30 years, was to avoid operating for very small deviations, less than 8 to 10 prism diopters, for a number of reasons. The greatest was unpredictability of the results, the likelihood for overcorrections, the likelihood that you would end up with another deviation and the patient wouldn't be happy. So we really avoided it. We tried to push the prisms. But with this new incentive, my partner, Steve Archer, developed a technique that I think mirrors some of the other minimally invasive surgical techniques, but this one is actually titratable in a way that I think some of the others aren't. And it's a very, very simple technique. It's called partial tendon recession. You just place a suture in one muscle pole. You disinsert 85 to 90% of the tendon, sparing one ciliary vessel, so you also do a vessel sparing at the same time. And which pole you disinsert matters. You can disinsert the nasal or the temporal pole on a vertical strabismus, and the disinsertion can correct 3 to 5 degrees of torsion as well. With the superior rectus muscle, if you incise from the nasal pole, the eye is going to intort 3 to 5 degrees. If you incise from the temporal pole, you're going to extort 3 to 5 degrees. And then the reverse is true of the inferior pole, just as if you're transposing muscles. It's the same kind of thing. You're shifting the vector action. So this has an extra benefit of being able to correct small amounts of torsion at the same time, and we always make sure and measure torsion when we're going to do these procedures. And then all you do is recess that one pole in whatever standard technique you want. Take that detached pole and recess it a measured amount. You can do that with a fixed suture, as we showed here. You can do it with an adjustable suture technique, and both of those work very, very well. Functionally, when you model this on the orbit model of ocular motility, it functionally is equivalent to a full tendon recession of half the amount. So if you recess a muscle, one pole 4 millimeters, it's essentially the same functionally as recessing the whole muscle 2 millimeters, but at least twice as predictable, because you're not taking one pole off at all. Therefore, you're reducing the risk of the anomalies caused by healing and scar shrinkage and things like that. So you're going to have only half the unpredictability of taking the whole muscle off and moving it. We've been using this procedure now for the past 10 years and treated many patients that I wouldn't have previously treated with strabismus surgery. And so our fellows recently reviewed our results with using this procedure with an institutional retrospective consecutive series of patients evaluated and treated from 2010 to 2015, the first 5 years of the use of this procedure. The patients were primarily small angle vertical deviations. It's possible to do this with horizontals as well, but there's such a large convergence and divergence amplitude that's not very useful, and most of the time these small angles are not benefited particularly in the same way that the verticals are. One pole of one or two vertical muscles was recessed using the partial tendon recession technique. The follow-up was at least 3 months. We monitored their preoperative deviation, postoperative deviation. We monitored surgical success, which was elimination of diplopia without correction. And we also looked at the dose response, which again has not been predictable, at least in the other minimally invasive procedures, in prism diopters per millimeter change. And we also analyzed 2 subgroups. One was Graves' disease, where this can come up frequently, and the other is reoperations. So we had 59 procedures in 50 patients. 3 procedures in 3 patients had to be excluded due to lack of follow-up. Average age was 59.6 years. Average post-op follow-up was 26.4 weeks, so about a half a year. And the overall sample is illustrated here. The pre-op deviations, again, the mean was about 4.5 diopters, but the range was 2 to 11 diopters in the overall group. Interestingly, we were able to titrate this, and you get about 1.5 prism diopters per millimeter. So you want to remember that number if you're going to try this technique. It's very, very easy. If you want to correct a 6 diopter deviation, you use a 4 millimeter recession of one pole of the muscle. So again, very easy number to remember when you're in the OR. You don't have to have a lot of fancy tables. And it most of the time does not require adjustable suture. And the post-op deviation on average was 0. I mean, again, some were over and some were undercorrected, but it's quite symmetrical when you use this technique. In Graves' disease as well, the dose response was about the same, about 1.5 to 2, a little bit larger prism diopters per millimeter, but very, very similar. Again, the post-op deviation was quite good. The range of responses, though, was somewhat greater, from -9 to +5 prism diopters. Now, in reoperations, the technique does not work nearly as well. It seems to have a larger dose response, around 2 to 2.5 prism diopters, but there's a much wider range post-operative results, so it's much less effective when doing reoperations. Looking at prism independence, again, that was the goal of this. And again, these patients came in not wanting to wear glasses, and they had good vision. They didn't need glasses for vision correction. So overall, 67% of our 57 patients were able to go with prism independence and glasses independence, spectacle independence, for most things. Possibly they would need reading glasses, but that was the goal of this surgery. We then individually looked at the Graves patients and the re-op patients. The success rate for spectacle independence in the Graves patients was 60%, again, very close to the total group, whereas in the reoperation it was only 29%. So this was a much less effective procedure in fully making patients spectacle independent in the reoperation patients. Again, looking at the surgical effect per millimeter, you can see that it's a nice balance. You get some that have slight undercorrections, some that have slight overcorrections, but really the patients in general were very happy with the procedure, and the majority cluster right around the center. And the same is true of the surgical results. Again, the vast majority are in the 0 prism diopter deviation and spectacle independence range, with, again, a relatively symmetrical number of under and over corrections. So in conclusion, partial tendon recession is an alternative to prism correction and procedures such as the mini tenotomy, mini plication, free partial tenotomy, and other procedures like that for small angle vertical deviations. We have a comparable orthophoric post-op outcome to those procedures between patients with and without Graves' disease as well. So it's useful for Graves' patients, it's useful for the general patients with decompensated phorias, again in that small deviation range. And it's very easy to remember the dose response, about 1.5 prism diopters per millimeter. Reoperated muscles, unfortunately, were less predictable. Thank you.